Family illness trajectory. Normal course of the psychosocial aspects of disease for the patient and the family. It indicates normal and pathologic responses, thus enabling family physicians to formulate a therapeutic plan. Knowledge of the trajectory allows the physician to predict, anticipate, and deal with the family's response to illness. During the course of illness, the family passes through various stages. Stage 1, onset of illness. Stage 2, reaction to diagnosis, impact phase. Stage 3, major therapeutic efforts. Stage 4, recovery phase, early adjustment to the outcome. Stage 5, adjustment to the permanency of the outcome. Mnemonic, ORMA. Stage 1, onset of illness. The warning sign of malaise which initiates preliminary stage of the illness. The stage experienced prior to contact with healthcare providers. Medical beliefs and previous experiences provide influence to meaning of illness. Nature of onset may play an important role on the impact of illness on a family, and some meaning of experiences are formulated here. Responsibilities of the physician. Explore routinely the explanatory model and fear that patients bring to the clinic setup. Explanatory models. Culturally determined beliefs that individuals hold about misfortune, suffering, illness, and health. These models are shaped by and shape societal expectations of the sick role, individual illness behavior, and help seeking. With inappropriate label of illness, acknowledge and explore the conflict the patient may be experiencing. Explore several aspects of pre-diagnostic phase of patients and families. Stage 2, reaction to diagnosis, impact phase. The physician who presents the diagnosis is responsible for making a clinical judgment about the amount of information the patient can absorb given his present level of anxiety or shock. It is important that the physician elicits explanatory model of diagnosis to patient if disease is not life-threatening and patient is liable to be unduly alarmed. Disease and appropriate treatment can be described according to the patient's level of understanding and understanding. Unnecessary frightening anxiety may occur if information is not understood. Give small doses of information over time if the diagnosis is particularly traumatic and the patient and his family may not be able to receive so much. If diagnosis is confusing and stressful and shuddering, the family physician must provide support and continuity of care, interpret findings which are misunderstood, offer advice and encouragement, and clarify meaning of specialist's message and outcome of illness and operation. 2 planes or areas by which family and patient react and adjust. Emotional plane. During onset of illness, initially there is denial, disbelief, and anxiety. Protest diffuse directly over unfairness, minutes to hours. This is followed by emotional upheaval characterized by strong emotions such as anger, anxiety, and depression. Depends on disrupted roles and channels, period of weeks. The last phase is accommodation, during which the patient and the family learn to accommodate and accept the diagnosis. This is very important for the implementation of therapeutic plans. Cognitive plane. Phase 1. Initially, there is tension and confusion with probable lack of capacity for problem solving. Threat sets in motion tension reduction mechanism. Phase 2, repeated failure in deriving the diagnosis may lead to exacerbation of tension and increased distress. Resort to prayers, still earn capacity for problem solving. Phase 3, increasing assessment and receptivity of family to new approach for relief of distress. Some go doctor shopping, some are willing and capable for active participation. Time for real opportunity for the physician and other health workers to assist family in realigning roles and expectations, learn new skills, and make adjustments. Willing to take responsibility. Phase 4, eventual acceptance of the diagnosis will enable them to mobilize resources and reorganize the family. Quality of family reorganization. If there is no movement towards this phase, the family will be inefficient in achieving healthy adaptation to the crisis and reorganize at a more dysfunctional level. Responsibilities of the physician: anticipate a number of problems and help families to cope and adapt more through family conferences, discussion with parents, etc. Specifically, the family should from the very beginning be encouraged to make clear to each other and to the patient the nature of the illness by helping family maintain openness that allows sharing and support. Pattern of non-sharing or silence limit the openness and spontaneity of families and hampers their ability to share and openly support each other. The process of isolation is more terrifying and may be perceived as abandonment by the patient. The physician should know that feelings of guilt are natural response to stress of grief and loss. Family members may have the irrational feeling that they personally caused the patient's disease. The physician should help family members anticipate such feelings and make realistic efforts to relieve the patient of self-blame through careful explanation of etiology. The physician should help family members assess the likely effect of the illness on the family, predict problems likely to arise, and develop plans for realistically coping with them, and assess the family's capabilities to deal with such stress. The physician should briefly help the family understand some of the problems as well as benefits to be expected from family and friends who offer support. Offer alternative interpretations of proposed therapeutics bolster families' denial and inability to accept reality. Stage 3. Major therapeutic efforts. Management therapy represents one of the most challenging and rewarding part of medical practice. The physician should deal with multiple variables, works in harmony of the wishes of the patient and family, and coordinates all aspects of the therapy, which involves specialists and others. Critical issues in choosing therapeutic plan. Psychological state and preparedness of the patient and family determine the choice of therapeutic plans, as well as the alternative choices. If the patient's belief system and trust in therapeutic modality is at variance with that of physician, he may resist attempt at education and reassurance. Thus, the physician should investigate for signs of non-compliance. Some of patients' families are not emotionally equipped to undertake some form of therapy, so other professional help should be obtained. Assumption of responsibility for care very early in the treatment plan. Thus, we have to establish and define responsibilities of each party, give realistic role to everyone. Economy of therapeutic plan. Of what good is therapy if family cannot afford it? The sickness will have devastating effects on the family, economically speaking. Diligence on the part of physician in keeping costs down by involving family in all major decisions which affect the patient, as in requests for tests or referrals which are really necessary. Economic impacts of illness. Emotional trauma, social dislocation, economic catastrophe, wipes out family savings. Lifestyle and cultural characteristics of a family are important in choosing a therapeutic plan. Effects of hospitalization, surgery, and other major therapeutic method are emotionally stressful for the patient's family. There is fear and concern in the families who are still essentially helpless, unable to participate in the suffering or need to relieve the constant discomfort or anguish. Hospitalization gives rise to stressful logistic problem. Father, special economic burden. Mother, greatest impact on other family members. It poses high risk of family dysfunction. Children, special syndrome of emotional problems of families. Hostility, abandonment. Parents, helpless, guilt, frustrated, or hurt. Geriatric, vulnerable to fears of death, rejection, abandonment, loneliness, and helplessness. Hospitalization, loss of member, reserve position upon return, conflict between family and hospital staff, intrusion. Responsibilities of the physician. Remain open to the family, indicate they will not be abandoned, provide them information. Deal with multiple variables, consider all factors in planning, work in harmony with patient and family, coordinate all aspects of therapy, anticipate pathologic response. Such responses of family members occur when there is severe emotional symptom of deep depression, psychological reaction, and organic symptoms, behavioral problem like addiction to alcohol, work inhibition, and pathological acting out. Stage 4, recovery phase, early adjustment to outcomes. Return from the hospital or major therapy initiates a period of gradual movement from the role of being sick to some form of recovery or adaptation, with corresponding adjustments of relation within the family. Experience of recovery or adjustment to the illness outcome is an important phase for patients and families. It varies according to the type of outcome anticipated. The simplest outcome is return to full health. Gains from illness experience: patient nurtured and allowed to take over the abandoned obligation, new responsibilities, and privileges when sick. Partial recovery, followed by a period of waiting to learn if disease will return, or fear of death because of long period of waiting. They maintain constant sense of vulnerability. Recovery is quite different if it requires acceptance of a known permanent disability. Responsibilities of the physician: deal with immediate effects of trauma, alleviate anxiety and assure adequate rest. Psychological support can be given through understanding and repeated reassurance. Explore a level of understanding of patient and family. Call on other members of the family for means of support. Try to find out how members understand what happened. What kind of labeling do they have? Do they label person as still ill, or do they label him as once again well or has returned to health? Stage 5. Adjustment to the permanency of the outcome. This points to the family's adjustment to crisis. The second crisis occurs as family realizes that they must accept and adjust to a permanent disability. The whole family must begin and give up hope for the patient's full return to health. They have to accept that life must go forward, and pattern believed to be temporary must be accepted as permanent. The family physician should be aware that continued unwillingness to incorporate that reality of the permanency of the loss may be a sign of pathology. Coping mechanism is developed during earlier stage of family adjustment. Person who is sick continued to be treated as sick, and he is treated as a patient and not reintegrated into the family. Treat patient as recovered, full, responsible person. For acute illness, there is potential for crisis, especially when family routines are suspended. Emotions are high and can lead to anger, especially if the family perceives that the care given by the doctor is not satisfactory. Because of the suddenness of illness, family might find it difficult to face the stress. What the family physician can do is facilitate healthy response or acceptance of diagnosis and recognize danger signals such as delayed or prolonged reaction. For chronic illness, because of prolonged fear and anxiety, there is a higher incidence of illness in other members of the family. If the chronic illness brings about additional burden and sometimes feeling of guilt, especially if the sick member was previously neglected, then as a result of this feeling, the family becomes overindulgent toward the sick member, and this will later result into feeling of overwork. Thus, anger and resentment toward the sick member sets in, leading back to feeling of guilt later. What the family physician can do is encourage ventilation of feelings, give reassurance and reinforcement for care. For terminal illness, this is highly emotional and potentially devastating. The moment of diagnosis of a major debilitating or terminal disease is often remembered by patients and their families as the single most difficult time of the entire illness experience. As a reaction to shattering diagnosis, the patient and his family anticipate grief reaction. If the family is functional, members will be drawn close together to provide care and support to the patient and to each other. If the family is dysfunctional, it can be the seed for future family discord and breakdown. The initial response to diagnosis of terminal illness is that of shock and overwhelming anxiety, as they respond to the pain with denial. The physician can assist the patient and the family in relating to healthcare system, aid the patient and the family in efficient and functional readjustment, provide quality care. Home care is the best and most accepted and the least demanding, thus it should be facilitated. Family reaction to death. In after prolonged severe illness and adaptation and reaction are already accomplished. Death comes swiftly and MD to assist family to cope. Stage of denial, few days to few weeks. If prolonged, pre-morbid pattern of abnormal behavior, anger, depression, bargaining, and acceptance. Thank you and God bless.